much for joining. The Adam Smith Society and the Darden Healthcare Club are very excited to jointly host tonight's debate on healthcare access and affordability in the age of COVID-19, more regulation or less. The Adam Smith Society is a project of the Manhattan Institute. It's an expansive chapter-based network of MBA students, professionals, and business leaders who work to foster debate about the moral, social, and economic benefits of capitalism. The Adam Smith Society provides a venue where members can engage in meaningful dialogue about free enterprise with fellow students and professionals, as well as prominent figures, journalists, and public officials. Launched in 2011 in partnership with the Maryland G. FEDAC Capitalism Project, the Society has grown to more than 40 chapters at elite business school campuses and major cities in the US and abroad. If you enjoyed this event and you aren't a member, we encourage you to reach out about joining the club. And we're excited to be partnering with the Darden Healthcare Club. Andrew, will you say a few words about the Healthcare Club?
Sure thing. Thanks, Kelly. So the Healthcare Club is dedicated to promoting awareness of core and trending issues, as well as opportunities in health-related fields. We partner with both academia and industry to advance understanding of emerging interests, policies, and business movements across the space. Importantly, for events just like this, we help sponsor educational and speaker programs on all aspects of the healthcare industry, providing information and guidance about career opportunities in healthcare and networking within the UVA community and in partnership with other MBA programs. We're thrilled to co-host this event with Adam Smith Society. And likewise, if you're interested in joining the Healthcare Club, please let me know. Now I'll turn it over to Kelly again to introduce our speakers.
Thanks, Andrew. So first we have David Kendall. As a Hill staffer in the early 1990s, Dave crafted healthcare reform legislation known as managed competition. While health reform under President Clinton failed, that legislation formed the essential architecture for President Obama's successful effort 15 years later. As such, Dave understands that public policy requires talent and patience. Dave leads Third Way's health policy work with a focus on fiscal impact. As part of this work, he is creating a fresh approach to restraining healthcare costs. This approach combines traditional and behavioral economics to create new policy tools that anticipate the potential irrationality. Dave creates new policy ideas, develops communication strategies to win support for them, and builds political alliances that can lead to their enactment. Dave also works to achieve universal coverage by building on the success of the Affordable Care Act. He has helped in the fight against repealing the landmark legislation and works on new ways to ensure that every American has affordable coverage and access to quality care. Prior to working on Capitol Hill for Congressman Michael Andrews and James R. Jones, Dave studied public affairs at the University of Chicago. He has achieved a unique work-life balance by living in Montana with his wife and 2 sons while commuting regularly to Washington, D.C. Thanks for joining us, Dave.
Good to be here.
And we also have with us tonight Dr. Robert Graybois.
That's okay.
Sorry about that.
Right on cue.
Oh, I was afraid that was going to happen. All right. Dr. Robert Graybois is a senior research fellow and healthcare scholar at the Mercatus Center at George Mason University. Author of Fortress and Frontier in American Healthcare, his work asks, how can we make healthcare as innovative in the next 30 years as information technology was in the past 30? And how do we bring better health to more people at lower cost year after year? Previously, he was a healthcare advisor for the National Federation of Independent Business, economics professor at the University of Richmond, regional economist, director of education at the Federal Reserve Bank of Richmond, and sub-Saharan African economist for Chase Manhattan Bank. His work has taken him to Europe, Africa, and Central Asia. An award-winning teacher, he has also taught health economics and graduate programs at Virginia Commonwealth University, the University of Virginia, George Mason University, and the George Washington University. His degrees include a PhD in economics from Columbia University, master's from Columbia University, Virginia Commonwealth University, and the College of William and Mary, and a bachelor's from the University of Virginia. He has chaired the National Economists Club, Richmond Association for Business Economics, and National Association for Business Economics Healthcare Roundtable. He won the Reason Foundation's 2014 Bastiat Prize for Journalism, an international competition for writing that demonstrates the importance of individual liberty and free markets with originality, wit, and eloquence. Thank you so much for being with us, Bob. We're glad to have you back with UVA.
Glad to be here.
And Andrew has graciously connected us to tonight's moderator, Peter Carson. Andrew, will you introduce Peter?
Sure, yes. So in addition to being my former managing director, Peter Carson leads the North America Public Affairs practice at Weber Shandwick Powell Tate, helping to devise and oversee integrated communications programs on behalf of corporations, coalitions, trade associations, and nonprofits. His work with clients on healthcare issues has included helping to build and manage a coalition of pharmaceutical companies and patient advocacy groups to combat unregulated pharmaceutical manufacturing by compounding pharmacies, which contributed to enactment of federal legislation, the Drug Quality and Security Act of 2013, which passed with overwhelming majorities in the House and Senate. Peter started his career with former Representative Christopher Shays of Connecticut, one of the last remaining moderate Republicans who regularly worked across the aisle on bipartisan legislation. In his role as Chief of Staff, Peter oversaw enactment of bipartisan legislation, the Congressional Accountability Act of 1995, which placed Congress under laws it imposes on the private sector. Peter currently chairs the National Board of Mental Health America, a leading community-based nonprofit dedicated to addressing the needs of those living with mental illness in our communities. Peter received his Bachelor of Arts in English from Kenyon College. And with that, I'll take it away. Looking forward to the discussion. And thanks, Kelly, for having us.
Yes, and thank you all for joining. When Andrew reached out to me to moderate this panel, I, in fact, told him all of those talking points that he just went through. And at the end, he said, actually, we really just need someone to work a 5-minute timer. And if you can do that, you'll be good. So you know, this is not about Peter Carson. This is really about hearing from David Kendall and Bob Grabois. And in fact, I'm going to take my time, my timer role very seriously. But this is, let me just give you a sense of the format for the next hour. It's sort of 5-minute chunks. We're going to have 5-minute opening statements from both. I will pose a question and both will have 5 minutes to respond. I will pose a second question for discussion. They will both have 5 minutes to respond, and then there'll be 5 minutes for closing. And then after that, we very much look forward to your questions and opportunities to engage in the dialogue. So let me just try to perhaps tee up the issue for discussion, which is, you know, here we are all living very intimately with this pandemic. This is not one of those issues that you hear about or read about. This isn't some arcane piece of policy that perhaps you've studied in school. We are all literally living and breathing this in our personal lives, in our professional lives, and then for all of you studying it and thinking about it as David and Bob are. And I think that makes this topic perhaps the most vibrant and personal of any issue that we could possibly talk about. So I'm very excited to hear from the two speakers about more regulation, less regulation, everything that we're witnessing and dealing with as governments in the United States try to get a handle around this encompasses so many aspects of our healthcare system. And yet here we are in a third wave, feeling like perhaps we haven't conquered it. Perhaps we couldn't conquer it. Europe is seeing a surge in cases. The US is seeing a surge in cases. And that then raises questions about what is the extent to which we can control it? What is the extent to which we can treat it? What is the extent to which we can vaccinate against it? And all of those components are in play as we're reading the news and thinking about these issues and wondering where we go. Successes and failures, I think, is just a core piece of what we're all watching and studying. And so with that, I don't want to take any more time, but would rather go to opening statements. And so, David, if you want to start out with 5 minutes, I will do this at 5, maybe 4:45. Give you a sense that we're on time, so we can stay on track. And then, Bob, we'll hear from you for opening statements. So, with that, David, go ahead and take it away.
So yeah, thank you, Kelly and Andrew and Peter. Really is a great opportunity for a civic and civil debate. I've known and respected Bob for years, and I don't think he'll be interrupting and yelling at me. And I also want to thank the Adam Smith Society and Health Club at Darden for arranging this kind of discourse, which kind of seems like an endangered species in the political world these days. So I have 3 points for my opening remarks. First, the COVID-19 pandemic vividly shows that health is the product of collective and individual actions. Second, the dominant political ideology, which has produced Donald Trump, has sacrificed our nation's health by relying on individual action to the exclusion of collective action. And third, we need more collective action to regain what the nation has lost under Trump. We need to balance collective and individual action, which is Joe Biden's approach. So let me go through my 3 points one by one. First, COVID has illustrated the need for collective action to keep people healthy. Let me give you some examples. With COVID-19 spreading asymptomatically, if you don't wear a mask in public outdoor areas, you are putting yourself at risk and your actions endanger others. Your health and the health of your loved ones depends on how people behave collectively. Another example is the management of healthcare resources. That requires collective action because of limited capacity. If a hospital is full of COVID patients, it can't take care of other COVID patients and people with other ailments. We've also seen the benefits of making testing, treatment, and prevention free. Controlling the pandemic is a public good. Making those services free is a good way to encourage people to take actions that syncs with collective needs. The final example is how the economy and COVID prevention go hand in hand. People won't resume normal economic behavior if they're afraid of getting sick and spreading the disease. Social distancing and mask wearing regulations have enabled reopenings. My second point is that collective action on COVID has suffered in the name of less government and caused people's health to suffer. The best example is the politicization of mask wearing. Instead of following the science, Trump and others mocked and resisted mask wearing. Republican governors sued cities and counties who wanted to protect their communities with mask wearing. And you just got to wonder, how did mask wearing become such a political issue? And I think it's because it's a threat to the dominant political ideology that says we'll all be fine if we just take care of ourselves. And wearing a mask is just a very concrete action that says our lives are interdependent. And then there's healthcare workers. You know, we're endangering their lives by wearing single-use masks repeatedly or trying to use makeshift gear. Trump delayed the invoking of the Defense Production Act to require companies to ramp up production of N95 masks, face shields. We all have seen that horrible story of limited supplies at a time when those supplies and needs were forecast. And then lastly, in the middle of a pandemic, the Trump administration is arguing before the Supreme Court to end coverage for over 20 million Americans with no plan to replace that coverage and no plan to protect millions more with pre-existing conditions. So my third point is that we need more collective action to regain what the nation has lost. We need to keep COVID under control. We need early detection so that communities can tighten up social distancing and mask wearing before the outbreak gets out of hand, as we're now seeing with the third wave, which, by the way, is far worse than it is in Europe and other places. We need to ensure equitable distribution of the vaccine also. Black Americans and Hispanics are much less trusting of a vaccine, and yet those are the communities where COVID spread is the most likely, and a vaccine will do the most good. And in general, we need to get costs and coverage for everybody. We need to, my organization, Third Way, proposes a cost cap for everyone in the country based on their income, so healthcare is affordable across the board. and that we have automatic enrollment for everybody who qualifies today for free coverage under the ACA, but do not enroll. So how do we balance the collective and the individual actions without going overboard? Well, we build on what works and we use steady progress, not major overhauls. I think the test of whether we've gotten to the right balance will be when we're wearing a mask and getting a vaccine and other preventive efforts are seen as a patriotic duty. With that, Bob, take it away.
Well, maybe I'll actually be the third way, since I've made the last 7 years or so of my career aimed at irritating people in both parties. And if I were to look over the experience of this year, I can come up with a long list of things that both parties have done right and both parties have done wrong. And I actually, I'm not sure on balance which has been better or worse. So I'm mostly going to stay away from the politics. But the overall question, to regulate or not to regulate, that is the question. My longtime argument has been I'm not anti-regulation. On net in American healthcare, I would say on balance, if you were simply looking at numbers of pages and words, we could do with less regulation, but we need smarter regulation. We need some reconfiguration of where the responsibilities lie across federal, state, local, and private sector for that matter. And I think it's been powerfully reinforced in 2020. Over the last, when Dave and I first met, we were both talking about the run-up to the ACA. In the last 7 years, I've largely taken a big look back and said, if I look at most of the healthcare policy discussion of the last 75 years, on both sides, both parties, both ideologies, it's been somewhat misguided by focusing almost entirely on the demand side. And let me explain. So in 2009, we had a certain number of doctors in this country, a certain number of nurses, a certain number of hospital beds, a drug formulary, lab equipment, et cetera. And in 2010, we passed the Affordable Care Act. Now, all those resources were pretty heavily utilized before and after. A lot of things changed under the ACA, but fundamentally, we didn't change very much about the quantities of those resources, nor of how we combined those resources to form healthcare. So for you business students and others, we didn't change the resource constraints or the production function very much. We did change patterns of demand. We changed patterns of funding, but fundamentally it was a redistributive act that some people got better care, some people got worse care, some people got more, some people got less, some people paid more, some people paid less, and all through different circuits, whether it be taxation or premiums or out of pockets. But And to be perfectly fair, I've made exactly the same argument about practically every one of the repeal and replace plans that has come and gone from the Republicans. That essentially they would move the chairs around on the deck of the Titanic, but not really solve the problems. And I would make the same arguments and have in writing about single payer, about public option, about all of these, or many of the more micro regulations of trying to demand that doctors or pharmaceutical companies provide more care at less money. So what I focused on and where I really think of the changes that we need in regulation is on the supply side. And in 2020, we've seen a massive shift in this. I would say really that we've had more innovation in the past 8 months than I've seen in 25 years as a health economist, 40 years as an economist. The FDA had to suddenly change its operating procedures to make sure that we got swifter approval of vaccines. Medicare shifted the way that it paid for telehealth and its willingness to pay for telehealth in different ways so that we could smooth demand across the country. Certificate of need, which I'll talk about a bit more later, placed massive, terrible constraints on the addition of hospital beds, pieces of equipment. And with COVID, the states blue, red, purple, whatever, said, you know what, we don't need those. If you want to add beds with your own money, please just go ahead and do it. Scope of practice, if a nurse practitioner wants to practice up to the level of his or her training, we stopped you before, we're not going to stop you now. And if a doctor in Idaho wants to treat a patient in Virginia via telehealth, please, we're happy to have you do it. And I think those are all cases of massive, sudden reduction of regulation and smarter regulation. And I think we've seen enormous change in this year. And I'll cut it off at that. We're at the 5 minutes.
Well done. Thank you very much. So my first topic that I want to throw out for discussion, you both touched on, but perhaps we can explore it a little bit more, which is addressing the systemic strengths and weaknesses in the American healthcare system. And sometimes healthcare discussions and debates and dialogues in the United States sort of go to one extreme or another. We can talk about single payer, or we can talk about the existing systems in very much of a plural form in the United States. And as was touched on, the federal government, the state governments, local governments, whether you're a veteran, whether you are poor, or whether you're a senior. I would love for you to both talk about these systemic strengths and weaknesses in the healthcare system, and how the COVID-19 pandemic in the US is either evidence of whether there should be more or less regulation or intervention in those systems, and the extent to which you see strengths and the extent to which you see weaknesses in those systems. David, we start with you again as the first one, and again, 5 minutes.
Sure, thanks. And I appreciate Bob's comments as well. We probably would agree on more things than we would disagree on, I would imagine, in a serious discussion. But unfortunately, we're not the ones in charge. My favorite lesson from health policy is that the American healthcare system is truly pluralistic. I mean, if you look at most of the other countries in the world, they are represented in our healthcare system. For instance, the British NHS system, which is a publicly employed set of healthcare workers, is much like our veteran system. The employment-based healthcare system, where most people get their job, it's roughly like the German system. The ACA, which has individual choice and did have an individual requirement to purchase coverage, is like the Swiss system. Our Medicare program actually shares the name of the Canadian Medicare program for the whole country. So what we've done is we've pulled, kind of like classic Americans, we just sort of pulled what was available as a model at the time these things were enacted together, and we have a kind of a potpourri of systems. We don't have one system. I don't think we'll ever have one system. I'm not a single payer supporter myself, but I do respect the sort of leadership that is called for by people who support more government action. And I think that's where our weaknesses come in. We rely on leadership at a time of crisis, and in order to pull these systems together and make them work together better. We don't have that built in. We don't have a traditional monarchy and parliamentary systems of government where one party is in charge at any given time. We have a divided government and checks and balances. So we need to have leadership that pulls these disparate elements together and makes it work as a coherent whole. And clearly we have utterly failed at any kind of performance measures on COVID. Our death rate and deaths are higher, our infection rates are higher than most other countries. I mean, for a little while there, India was actually climbing faster than us in terms of, but now they've got it under control, and we're back at the top in terms of new daily cases. So clearly the weakness of our system has been that we haven't had a leader that can pull us together and do that. I'll give back the balance of my time.
Bob?
So again, and I'm a little bit more of an agnostic than Dave is as to how we have done versus other countries. I think we're still in a period where one country goes up and then it goes down, we go up, and I think it'll be some time before we know how well we did on balance vis-a-vis the other countries, whether it were simply timing differences. So I'm not ready to call the winners and losers politically in that way, nor am I willing to say that we've done better or worse. There are clearly other countries that have done worse in some ways. It's been highly varied regionally. New York State had some of the worst episodes of any location on the face of the earth in the early days of the pandemic. Now they're doing rather well. Again, over time, I don't know how it will look in retrospect. But what I do know is, again, I focused much more on the supply side. And here I think we've done some marvelous things, magnificent changes over the course of COVID. There was an interesting anecdote at the beginning. We were facing the possibility of a desperate shortage of masks, of the serious masks, the N95 type. And the Battelle Corporation in Ohio said, we've just come up with a cleansing device that can clean massive amounts of these things. And the FDA, reflexively, as it does, said, okay, well, we're going to sit on this for a while and think about it and test it real well. And there was outcry from both parties, both sides, saying, we don't have time for the usual FDA techniques. And somehow they relented and allowed this thing to go, and the machines were distributed around the country. We've had, used to be practically every state, I think every state had a certificate of need law. This meant that in a given state, in your state, you wanted to add a hospital bed, you wanted to build a new hospital, you wanted to buy a CAT scan machine. Here in Virginia, you have to go to the state government at a high cost, a length of time, and say, may I please spend my money on this stuff? There's a crack team at Mercatus that I think has done the fundamental work on this. Matt Mitchell and Tom Stratman, great data to show that all of the reasons that were ever given for con laws, they debunked one by one. Well, this year, all of a sudden, again, the state said, we need this stuff. We're going to just jettison these con laws and allow you to build these things as you see fit, because frankly, we need it. I'm doing some research now on licensure. I'm something of a devout federalist. I like states having autonomy. I like the laboratories of experimentation, but sometimes it has more negative effect. And so our state-by-state system of medical licensure is problematic. Training to be a doctor in one state is pretty much the same as training to be a doctor in the other state. And the states have really thrown up protectionist barriers against doctors from other states moving on in, crossing borders. Well, a lot of that just got thrown out the window with COVID. I remember there was New York State was in desperate straits at the beginning. A plane load of doctors from Colorado flew in to help. That would have been prohibited before. This year it was, okay, we need it. Arizona last year implemented a really interesting law that said you can move to Arizona and set up your practice the next day. Just tell us you're here, and then we'll work on your licensing later. And essentially the whole country went to that sort of a system all of a sudden, which I think is a major benefit. And again, it's less regulation and it's smarter regulation. Same with telehealth. Medical societies, state governments, have fought it for years. They've had all sorts of bizarre restrictions on who can use telehealth, under what circumstances. This and a lot of doctors were sincerely questioning the efficiency, the usefulness of telehealth. All of a sudden, we learned massively it's pretty good, and I think it's going to be here to stay. So the key for me is, rather than all of the insurance machinations that we usually talk about, figure ways on the supply side to make our resources less expensive and to make much better, more efficient use of them. And I'll turn it back over to you, Peter.
That was amazing, Bob. That was literally 5 minutes, and I didn't even raise a finger. That was extraordinary. Yeah. Well, let's talk as the next question. Sort of let's look forward now. We sort of have looked back a bit on what we've seen and some good examples of where there's been movement and adaptation. But whether you want to take this question as someone mentioned a monarchy, you're king, and this is your opportunity now to take lessons learned from COVID-19. What would your agenda be? The other way to take the question, and you're welcome to mix and match, is what should the agenda be of policymakers and others? What are the most important lessons learned in terms of, okay, we have this system, here's how it functioned, here's how it didn't, here are the specific reforms that are going to do the best, that have risen as a result of what we've experienced through this pandemic. And on this one, Bob, you get to go first.
How about that? So I'll take some exception with one aspect of what Dave was saying, which is about national leadership on, for instance, masks. I wear my mask religiously when I go out, and I get irritated when people don't, and I've written on that. And just a week or so ago, I wrote an op-ed on the strangeness of science and the risks of reading data. But that said, a good friend of mine who used to head up public health for one of the states and who used to be very high up in federal healthcare, told me that his daughter out in the Midwest had said, Dad, could you get one of your big name friends from Washington to speak on a Zoom meeting on public health? And he said, you actually don't want one of my bigwig friends in Washington because they don't actually know anything. He said, what you need is, and she was in the Chicago area, ask the head of public health for Chicago or one of the cities around there to speak, because that person is going to know a great deal more than anyone in Washington. Public health since the 1700s in the United States has been an extraordinarily decentralized effort. Yes, you can exert some national leadership, and again, on both sides of the aisle, I can point to problems that have been in that. But a lot of this really is up to the local public health officials, and many of the tasks belong at that level. Again, what major areas do I look at? And I forgot to turn my timer on, so I'm not going to be as good this time. How far along are we?
You've got 3 minutes. You're doing great.
Great. We're going to need some new institutional features. So there was recently a story about telehealth fraud. Well, that's expected. We've had a sudden institutional change. We're going to have to figure better ways to sleuth it and monitor it. And there's an area where, yes, we'll need some more regulation and some smarter regulation, and probably at the federal level. I've got I just had a public interest comment come out on physician reimbursement, recommending that CMS, Medicare and Medicaid services, increase their funding of non-physician providers, nurse practitioners and others, to allow some competition between physicians and others, both as a way of expanding our amount of resources and of cutting the costs, of switching to, say, reference pricing for telehealth. It's a good thing that we're paying for telehealth, but when we set it at parity, meaning we'll pay a doctor exactly the same for a televisit as we will for a regular visit, you may be tossing out one of the greatest benefits of all of telehealth, which is its capacity to lower costs vis-a-vis an in-office visit. I recommended reimbursing, which they've been doing during COVID, but I would suggest making it permanent, reimbursing doctors for talking to you on the telephone, as you would with a lawyer or an accountant or others. An awful lot of good medicine can be conducted in a 5-minute conversation between doctor and patient. I've got an upcoming public interest comment with two colleagues, Darcy Bryan and Lyle Berkowitz, on the subject of electronic health records. The Affordable Care Act and some other legislation created what I consider to be a pretty poor set of electronic health records that are much better for billing than they are for clinical purposes. And in that public interest comment, which will be out at the end of this week, we talk about ways of actually making electronic health records useful for the patient and for the provider, more flexible, using more natural language. So this, and again, this is one of our themes, is allowing different sorts of EHRs to grow to the point that we finally figure out what works and what doesn't, rather than top-down mandate, this is what an EHR will be, and that's how we're going to do it. We've had 40 or 50 years of the demand-side regulation, and again, we've had 8 months of decreasing supply-side regulation, and for my dollar, the 8 months has done a whole lot more than all the 40 to 50 years of machinations with managed care revolution, Affordable Care Act, whatever the Republicans have done on that side. We've done an awful lot this year on the supply side, and I'd like to see it continue.
Great. David?
Right. Well, the risk of being too agreeable, I don't disagree with most of what you said there. But I do want to go back to something that you said earlier, because I think going forward, we need to look away from the areas where there seems to be a zero-sum game and look for the win-win scenarios, right? I would argue the ACA was a win-win because it protected people from financial devastation, from the insecurity of having a pre-existing condition, for getting coverage into the hands of people who previously have been systematically left out of the healthcare system, for having an alternative to employment-based coverage, which is never well loved by either Democrats or Republicans sometimes, and making a statement that we can sort of move our healthcare system forward. Now, it's been really hard, and a lot of us have had to work hard to defend it against what I think is pretty much a out of control, sort of self-interested ideology. But it's so far prevailed, and we've got one more test, I guess, before the Supreme Court. We'll see if it succeeds. But I think building on the ACA, or repairing it as it may need to meet the litmus test that the Supreme Court might put down on it, is totally worth it. But I also think that there are very specific things that I'm excited about. Like and we still need to do these things. Like, there are really good early detection systems that use digital thermometers that are connected to thermometers that have been proven to give a 2 to 3 week advance warning for COVID outbreaks. If we had that extra 2 or 3 weeks, the local public health agencies, who are, Bob's right, are in charge, can act more swiftly, because right now, what they're doing is they're basing their actions on testing that we know is completely inadequate in terms of measuring the speed and velocity of this of the spread. Another area that we need to work on is clearly vaccines. I don't think we're going to get away with just making it free. We might actually have to pay people to take vaccine in order to get that 70 to 75% level of vaccinations in our country in order to move beyond it. And that's not even considering the fact that a vaccine may have to be retaken every 6 months to a year, depending on how effective it is over time. I will applaud the administration for taking the money that Congress has used and using agencies like BARDA, which has been the prominent agency in sort of getting that funding to early developers of vaccines, is really going to pay off. I would have done 10 vaccine candidates and prepaid for all of those vaccines, but we got about 5, and that hopefully one of those 5 will work. I would also, on Bob's point about the supply side, totally in agreement. I think we need to better align incentives. It's really great that we've taken the restrictions off of telehealth, but there is a problem under a fee-for-service payment system if we paid doctors for each email they received and they sent, we would be getting a lot of junk mail from doctors. So we got to be careful with how we pay for this, and a capitated payment or subscription models for primary care docs and others to take care of the business of communicating with patients and arranging the records so that they're usable for other doctors. That's the kind of thing that we need to just sort of pay, I think, on a flat rate rather than on a fee-for-service basis. And then we can talk a lot about, and one of the most innovative things that the ACA did was to say, and this has actually turned out to be true, that make Medicare into an innovative payment system through the Centers for Medicare and Medicaid Innovation. We've actually seen more innovation coming from government policy from the CMMI program than I think we've even seen during this COVID period. I mean, I don't disagree that we've seen a lot of innovation here, but CMMI has really stirred the pot in terms of how doctors are paid, how they're evaluating their quality of care, and making the system more accountable. We just have got a healthcare delivery system that is not responsible for its outcomes. You talk to employers and about healthcare, and they go, well, we were responsible for producing a product and being held accountable for that. Where does that happen in healthcare? It doesn't on a regular basis. So making that accountability through measures of quality. We've got a lot of problems that we got to work through, a lot of regulations that are probably too much regulation in some areas and too little in others. We need to sort through, we need a robust debate that's centered on the fact that we can balance both collective and individual needs and not sacrifice one or the other. Did I hit my 5 minutes?
Like Bob, you were almost to the second, so I applaud both of you. You must have timers in front of you. Let me just pause here for a moment and say that after closing statements, we go to Q&A. And let me suggest to the participants who are on the call, go into the chat function and just go ahead and indicate that you have a question. And then I'll call on you, and I think that way we can sort of have an orderly Zoom Q&A session. So just go ahead and put it in the chat. I'll call it in order. I'll call your name, and then you can go on video and ask your question in your own articulation. You don't need to put your actual question in the chat. Just indicate that you have a question, and I think that'll give people an opportunity to speak. I think we probably may actually be a little bit ahead of schedule, which I think will be great for allowing for more opportunities for Q&A. I do, however, since we're a little bit ahead of time, I have just a sort of a quick question for each one of you. And because we're a little bit off the grid, maybe perhaps a minute or two of commentary on this is, my perception, having worked on Capitol Hill, and then having worked with associations and coalitions and companies in the healthcare space across the board, is that that healthcare in the United States gets very ideological very quickly. David, you mentioned how even the mask can become a political symbol, and suddenly we have you're for mask or you're against a mask, and our options suddenly seem very binary. But my impression, having worked on bipartisan legislation, both when I was on the Hill working for Congressman Shays and then working coalitions, is just like the two of you, just listening to the two of you, there's actually so much agreements. Even if you come at it from a different viewpoint, there's so many areas of consensus, and it's always led me to wonder, from a policymaking standpoint, should we jettison and put aside the notion that we need big sweeping legislative acts like ACA, where suddenly you find something you don't like, interest groups find something they don't like, and meanwhile there's all of this bipartisanship on lesser measures, and I can think of any number of them, children's health care, veterans health care, where it seems a lot less charged with politics. And so any observation you have on that point, and then we'll go to closing statements. So David, you want to take a shot at that one if you would like?
Sure. No, I think it's an excellent question. And the way I resolve that is that we need bold, decisive action that aims at a collective goal that we can get our minds around, that's acceptable to people, but yet we do it without massive disruption. And as we saw with the ACA, what was relatively minor disruption from that bill compared to what you would get with a single payer, that's kind of where we fall. We were never going to do the kind of disruption that single payer people would like to see. But at the same time, if we don't do something, if we don't you have to break some eggs, right? So the bifurcation in Congress is really, I think it works pretty well. A lot of the bipartisan issues do get handled in a bipartisan way. I mean, we've passed an amazing amount of bipartisan legislation this year, which no one knows about, and we will continue to do it. And so that kind of does work its way through. And so I think that there's reason to be hopeful there. I think we are having an ideological fight, and the Republican Party, frankly, is stuck on and healthcare has tripped it up, and it's just we've got to move beyond it. And we will. I think that'll happen in this election, and we'll go from there.
Bob?
Sure. So, yeah, a lot of good stuff there. So my favorite snark line that I use quite often is that in the healthcare debate, the Democrats believe that it is the federal government's job to diminish competition and interfere with markets, whereas Republicans believe that the task of diminishing competition and interfering with markets should be left to the states. But in both cases, you end up with the same sort of outcome. Both, whatever plans that they are, it is suppressing the possibilities of innovation, the different pathways. I'm going to pull out something, not that I disagree with what Dave said on it, but for instance, shifting to different payment systems, paying for something via fee-for-service, something else by a capitation. In one of the great books of the last 15, 20 years on healthcare, David Goldhill's book, Catastrophic Care, David said in there that the unique thing about American healthcare is not that we pay everything fee-for-service or that we should do capitation, whatever, but rather that we assume that there should be one type of payment system. That in his industry, he was from the communications industry, a great part of the entrepreneurship task is to figure out what kind of payment system is more efficient. Should we be paying for this, item by item, or should we capitate it all together and let different models flourish at the same time? And I think from Democrats and Republicans both, there has been the supposition we got to find the one way to do it. We're going to impose it from the top, whether it's imposing it at the federal level or the state level, and then we're going to make it illegal to do anything else. And so I would be much more open to a more fluid sort of a market. And I would say too, and this gets back to Dave's comments on masks and other things. We are different from Europe in one other big respect. We are a massive, monstrous, highly varied country. And what works in New York or what doesn't work in New York isn't going to be the same in North Dakota or Nevada, whatever. And the other thing about those countries, if you want to say, well, they had this kind of a mandate on masks, whatever, which, by the way, the data are showing that the early mask mandates didn't work all that well in Europe either. But if you want to argue that they did, they tend to have unitary police forces. So they can set enforcement policies that are nationwide and uniform. Constitutionally, we do not have that capacity. And so it is, regardless of what we would like at the federal level, the states are going to have a massive amount of control over how things go. And I think the more we recognize that and deal with it, the more successful we'll be at actually navigating this thing.
Great. Thank you. Okay, well, it's time for closing comments. And since we just ticked over 2 minutes of where we should be, why don't we, I'm just going to pair closing comments to 4 minutes, and then we'll be right on schedule to take questions at 6 o'clock. So, David, do you want to go ahead and make a few closing comments?
Sure. I'm tempted to just, first of all, kind of thank, Bob and Peter and Kelly and Andrew for their work on putting all this for this whole event. But I'm tempted to just sort of, one of the big lessons I learned as a student of health policy is that in economic terms, healthcare is both a public and private good. And there tends to be aspects of it, in pretty much everything we do. I mean, my favorite, the way I think about it is with eyeglasses. We want everybody to have eyeglasses, right? Because if you're a kid and you can't read, you're not going to succeed at school. You can't function at work without eyeglasses. So that seems to be pretty much a public good. Although people can buy their own eyeglasses, and yes, indeed, they can decide what kind of designer frames they want to choose. So that was where competition works really well. But making sure everybody has good vision, got a test for their vision, and has access to eyeglasses seems like a public good. So with just a simple thing like eyeglasses, you got public and private goods all wrapped up in one, and you've got it. That's why one ideology here, one of the party of more government versus the party of less government, that doesn't really work. And I think the Democrats have moved towards, you've got to do both. We've had our big fight with over single payer. We've decided we're just going to keep a mixed system, and we're on track. And I'm really hoping that the Republicans will eventually get there as well, and we can have more concrete debates. The other big point I wanted to make was that, we do have a dynamic process. We have a great state-based system and a great federal system, and these things, the sort of balance and the flow work really well as the power shifts back and forth between the two systems, and that's something to be celebrated as well, because I think that a great thing about our democracy is that we have a pluralistic system that allows for innovation, but at the same time has some controls, some curbs on the excesses of capitalism. I don't think that any capitalist is appreciative of the high pricing power that happens in a lot of markets these days. We have pricing that's just out of control. And so we have some collective need to sort of exercise some control over that. Now we can argue over how to do that, and certainly we could have a good discussion all separate from that. Antitrust would be a good way to look at it. Some kind of limits, but the fact that we couldn't even get surprise billing done in this last Congress makes you recognize how hard this is. I mean, we had surprise bills that are clearly a market malfunction, and yet the providers sort of gummed that whole debate up. I think just to sum up, I think what Congress needs to do, and this is where I think we can all come together, is that the universal protection should be limited to what you're paying for out of your own pocket for your healthcare costs, and that you're guaranteed access to affordable care. And Bob, you appreciate this. In technical terms, it's a defined contribution for a defined benefit. Now, I know that's the demand side, but that's where I think the policy needs to go on the demand side, so that we have enough of political consensus on that in order to take on the supply side and the excesses that it produces, and the good things it has. I think we can have a lot of innovation underneath a system where the excesses are curbed, and that we have a very robust innovation system underneath that. So that's where I stand.
Great, perfect. It was right 4 minutes. So Bob, you have the last word.
Okay, so I'll do a little self-advertising here. In 2014, I wrote a monograph book, whatever. It's available on Amazon. It's available on our website, called Fortress and Frontier in American Healthcare, and it's 60, 80 pages of what I'm just going to very briefly say here, which is, I'm holding here an iPhone, and I pointed out in there, 30 years ago, I knew precisely one person who owned a cell phone. She was a very wealthy friend of my parents, who had, I believe, 7 houses. And the fact that, the sort of person who would have a cell phone back then was someone who also had 7 houses. And we were just at the very beginning of the internet age and the cellular age. And very briefly, Congress thought it was going to, there was a bipartisan consensus that said, well, these things are out there, these new technologies, we better start regulating them now. And somehow, both parties had a massive outbreak of good sense. Maybe the only time in American history. And they both said, you know what? Why don't we step away from it and let this technology grow itself? We realize there are going to be some very serious problems along the way. But rather than try to anticipate them and regulate them and run them from the top down, we're going to let this thing grow organically. And when there's a problem, we're going to step in and fix it. And David, I will say, for all the jokes about Al Gore inventing the internet, he actually was one of the major figures in doing this. So I do like to give him credit for that. But it was very much bipartisan. And what you got, I think just as much as eyeglasses, these cell phones have every bit as much and probably more public good power than eyeglasses. These things have probably played a major role in the last 25 years in reducing poverty to an extent that has never been seen in world history. That we've gone from, by UN standards, I think something like 25 years ago, 50% of people in abject poverty down to 10 to 15% in a relatively short time. And I'm hoping to God that that doesn't get reversed by COVID, and it certainly partially could happen. Anyway, we didn't have top-down mandates. We didn't, for the most part, didn't subsidize these things. We let the markets grow. We let people innovate. We didn't say, you know, Western Electric is going to have control over this, and we're going to throw money at Western Electric. Rather, they allowed people, you know, a couple of Canadian guys who invented the BlackBerry, and Steve Jobs came out of nowhere and invented this thing in a garage. And the same with Bill Gates. We didn't say IBM and Honeywell and Data General are going to have the contracts. You know, Dave talked about going subsidizing 10 vaccines, which in a way I think there's a lot of merit to it, though I would much prefer something that was incorporated in the 21st Century Cures Act that Congress passed, wisely, I think, called the Eureka Prizes, which is a retrospective prize for innovation rather than the government trying to figure in advance who's going to be the smart guy to figure this out. So rather than the government trying to figure out who Steve Jobs is when nobody's ever heard of Steve Jobs, the Eureka Prizes allow NIH to say, here is a big, fat pile of money. Whoever comes up with this thing, we're not going to guess who you are in advance, but when you're the first across the finish line, you get this wad of cash. I'd love to see more of that done. Prizes like that have a remarkable history dating back at least to the 1700s. But what 2020 has shown us is you can remove massive constraints. When you do, you can unleash innovators. You can still get excellent care. You can still get cost savings that are ultimately going to exceed anything you're going to get by trying more top-down, heavy-duty regulatory management. But it's a learning experience. And similarly, I'd like to thank you, Peter, and you, Dave, for a great talk. I'm looking forward to the Q&A.
Great. Thank you very much. Well, we have our first question from Amy Gill. So, Amy, do you want to go on video and go ahead and ask your question?
Sure. You both touched on it a little bit, but I was wondering if you could speak a little bit more to beyond Democrats and Republicans, but what role do powerful associations in this field with competing interests play in getting legislation passed or blocked?
I'd be happy to start on that one. People forget that our founding fathers designed Washington, D.C. to be dysfunctional. I mean, to stop stuff from happening. That was their intent. It was very hard to get, as we know. There were 2 attempts to create a federal government. The second one stuck, but it is very hard. So the associations play a critical role in stopping stuff from happening. They seldom play a constructive role in getting things to happen, unless it's kind of narrow. And instead of an association that represents a given industry, what you get is coalitions that try to get things done. the coalitions that build different bridges between different groups. I would argue the ACA was a coalition of the major industry players, the hospitals, the doctors, the pharmaceutical companies, the health plans. They all supported it. The only people that didn't support it were the Republicans. So in some cases, it can be very constructive. In other cases, they stop. So it's that's the art of politics, is the art of the possible, and it's deciding as a leader of the country what you want to get done, and then arranging the coalitions to make it happen. All right, at least to not let your agenda be scuttled by the various interest groups.
Bob, you want to take a crack at that?
Sure, I'll do some more shameless self-promotion. Last week I had a piece come out called Leftward Ho, in which my colleague Chuck Blothouse and I argued that over recent decades, we have not seen Republicans moving sharply to the right and Democrats to the left. They've both been moving to the left. The Democrats merely at a faster pace than the Republicans have been. And I was happy to see David Brooks picked it up and quoted extensively from it, so we're getting some play all over the country. But I think some of the issues we discuss in there, and tomorrow morning I've got a piece coming out on the question of why are we polarized? And I think it has a lot to do with that, of what we're talking about and how the ACA came out. I was talking to a friend who's a big ACA supporter, sort of. I mean, he's got his skepticism. And I was talking a little bit about the history, and Dave certainly was there at this point in history. Before the ACA, say 2007, 2008, it actually, as far as I was concerned, it looked like we were heading toward a bipartisan bill, which I was not enthralled with, but it was a sort of an intellectually coherent bill, Wyden Bennett. The Healthy Americans Act, which in some ways was a more radical bill than the ACA ever was. Again, I didn't support it, but it was an interesting exercise where they had roughly equal numbers of Democrats and Republicans who were co-sponsoring it. And I asked a Democratic friend who was a big supporter of it about a year after the ACA passed, what happened? What happened to your bill, and why did this get passed? And he sort of turned red and said, because every association in America came and said, yeah, pass it, but leave us out of it. We want to protect our turf. And what you got with the ACA essentially was everyone protected their turf except for the narrow sliver that ended up in the individual markets. And everyone said, that's fine, pass this big thing, just don't include us in it. And so to a large extent, people like I am, who are on employer-based plans, we're not all that affected by the ACA. It's a fairly narrow grouping of Americans who benefit from it in the way that Dave was talking. So by all means, the powerful institutions made a big impact on this.
If I can just take 30 seconds to offer a quick perspective on this question as somebody who's worked on both sides of it, both on the legislative side and the advocacy side. My one observation about the power of associations, just as David said, and both of you alluded to, that associations can be very powerful in deciding what they're against. I think one byproduct of that, and I think you saw it a little bit with bills like the corporate tax reform, is we've moved from the smoke-filled room of the old days where everything was done behind closed doors to sort of this hyper-transparency where everybody gets the chance to kill the bill at breakneck speed, to potentially going back to perhaps not a smoke-filled room, but a room where no one's really there. And I think what's happening is leadership are now trying to move bills and bypass the committee processes just so that they can try to move the process as quickly as they can before groups engage. So from my perspective, that could be good, that could be bad. It's changing, and leaders are going to have to figure out how to adapt to all the voices that are out there from an interest group standpoint. Andrew Kennedy, you had a question.
I did, yes. Thank you all for joining us today and speaking. So we're obviously all business school students, and we've seen the business environment transition rapidly with limited guidance. And then conversely, with the Defense Production Act, we've seen government interference. What's the right balance to achieve that guidance moving forward, especially as we consider new rounds of PPP funding and qualifications for that, and also as we enter this potentially new wave, how can we altogether restructure our business environments with potentially government intervention or no government intervention?
I always go first, Bob. Why don't you take this one first?
Okay, I would say one of the keys there, and this is something of which both parties are guilty, which is when they do regulation, it's not always predictable. So you are forced to guess exactly what are the parameters of this regulation going to be, how is it going to affect me, how is it going to be enforced. And so I think above all, whatever regulations you do, however much, however little, to the greatest extent possible, it should be knowable and predictable and behave in a relatively objective fashion. And I think very often the failing is that it's done on the fly. It's not done equitably. You have internal forces. And, well, you've got to follow the reg, but this guy's a friend of mine. He doesn't actually have to follow it. So I think the sort of the equitability and the predictability are above all the most important that you can do it.
Yeah, and I think that the areas where the Trump administration has been clear and decisive have shown that leadership works. I just to do some self-promotion, just did a piece on kidney care and praised the Trump administration's initiatives here, which have been long in coming. We have a huge problem with kidney care. We have people on dialysis that shouldn't be there. We have a healthcare system that utterly fails to prevent the kidneys from failing, and it was a very expensive and totally government-supported program. But the Trump administration signaled early on that they were going to do this. They produced a series of executive order and then regulatory proposals. Gave everyone a clear path to figuring out how to do it. And the result is we're going to get some changes. I mean, it's kind of problematic with still COVID happening, and providers are it's hard pressed to take on these big new challenges. But once things settle down, we will get some changes in this space. So that works. What we are missing with everything else you just talked about, PPP and protective gear and all the supplies that are needed for the vaccines. I don't see the plan. I mean, there's a plan that's sort of been published on vaccine distribution, for instance, that's very top level, doesn't have any details, and it's like, well, the military is going to solve this problem. It's like, so that's what we need. I mean, Biden has already written a longer plan than the Trump administration has, and he's not even in office yet. So I think expecting that from your leaders is what we need, and when we get it, it works, and when we don't, it's a disaster.
Great. I don't have any other questions in the queue. So is there anyone else who would like to ask a question while we have a few more minutes? If not, Kelly and Andrew. What's that?
We solved it all.
Solved it all, exactly. If there are no
Hyder just mentioned that he had a question.
Thanks everyone for being here today. So I used to work in the Senate before coming to business school, worked on health policy, so familiar with a lot of the challenges and legislation that came through over the past couple of years, but I'm just curious to see what everyone's thoughts are on, whether it's Trump presidency or Biden presidency, what would be on the healthcare agenda for either of those tickets, if any.
So I'll take the Biden side of things. I'm not sure if I could articulate anything on the Trump side. But with the Biden side, I think the first thing that you'll see is it will be COVID. I mean, if we can't get that under control, then the country's in peril, people's health is in peril, the political fortunes of the Democratic Party are in peril. The public is just frustrated and doesn't like what hasn't been done so far, and so it's really on the Biden administration to get the vaccine out there. And even with the vaccine, we're going to still need to do social distancing, and we're going to have to balance a lot of very tricky public health situations. So it's going to be COVID. And once we get that sort of hopefully under control, I think you'll see a big interest in sort of fixing the ACA. There's a whole series of fixes that we have just not been able to get to because of the political maelstrom over that. And I think we want to strengthen it. We want to make sure that, employment-based system is not good for a worker who is making $15 an hour and it's got a $3,000 deductible. That takes a year. It takes a month and a half to make that deductible in order to have some health care. And so clearly that's a problem that we need to start addressing. So I think we'll begin to see expanding the sort of strengthening the structural supports that the ACA has for lower and moderate income and middle income workers, and even upper middle income workers, and then seeing how we can expand those protections to the employment-based system. And then lastly, I think we'll see a continued effort to create some fiscal discipline in our country that we've sorely lacked under the Trump administration, with tax cuts that have exploded the deficit, and now we've got all this debt from the COVID expansion. And I think we'll begin to see some constraints on healthcare costs coming back into the equation as well, because we've got a Medicare trust fund that's going bankrupt even faster. We've got some really serious deficit problems as well that healthcare should contribute, should share to. That's all I got.
And again, I'll be more the man in the middle there. My supposition, the pessimist in me, says that regardless of whether it's a second Trump administration or Biden administration, an awful lot of the effort will be put toward rearranging the deck chairs and not actually making progress. And again, part of it is because the politics of it, we have worked ourselves, and again, it's those pieces that I've written recently. We're in a zero-sum game, and zero-sum games don't come up with very satisfying resolution, because somebody's ox will be gored, whatever. So as far as the deficit, I agree that's an interesting one, and in my leftward hoe one, we discussed that as being, there's a bipartisanship there. Neither party cares one whit about deficits anymore, and that is a problem. I've also written some things on why I think we're actually not going to spend less on healthcare going forward, nor, I've argued, and we can get into that another time, nor probably should we spend less on healthcare, but we certainly could be getting a whole lot more out of what we spend than what we do. So on the federal end, I'm not sure I expect much, maybe a little bit on the FDA, maybe a little bit on changing hospital law a bit to reduce some of the monopolies there. But I really think an awful lot of the optimistic parts come at the state level. With two colleagues at Mercatus, I produced something called HOPE, H-O-A-P, the Healthcare Openness and Access Project, where we look at the 50 states in DC and say which states are friendlier to innovation in telehealth and direct primary care, in licensure, in business structures. And I think really the states have an awful lot of capacity to improve things. And again, I think they've been forced to this year on the fly. My hope is that once this thing settles down, that they will not simply revert to their old bad ways. I had a colleague I've written with about the FDA, and he talked about being there during the AIDS crisis, where similarly there was this massive outpouring of political demands that we've got to get things through faster. People are dying here. And he said it ended up with people circling the building on a daily basis until the FDA said, okay, we're going to let things go through more quickly than we're used to doing. And he said it was rather inspiring to see, but as soon as the AIDS crisis settled down, the FDA went right back where it was. So it's my hope that this thing, that COVID will lead us into some permanent changes, that we're simply not going to revert to the bad old days the moment that it steps away from us.
Great. Well,
Just wanted to. Oh, sorry,
yeah,
Peter. Go ahead.
no, I just want to say thank you both for a great conversation, and thank you all for joining in the questions. Kelly?
Yeah, if we can just give a little virtual round of applause for Bob, Dave, and Peter, that would be great. Really appreciate you all taking the time out of your schedule to be with us this evening.
It was a lot of fun.
Thank you.
Very much.
Thank you. Bye.
Bye, guys.
Bye.